the sclera is the white parts of the eye. That's where we're going to see,
Where the hell are we? Oh,
you know, any redness, if it's infected, like that would be conjunctivitis. You know, the sclera becomes red because the whole clear coating over it is infected. The lacrimal system is like the tear duct system, the drainage. Movement, when we have our eyes examined, there's something called the 6 cardinal fields of gaze. So up and down, side to side, and then lateral corner to lateral corner, both sides. The 6. We want to make sure that our eyes can follow a pen or a finger to the 6 cardinal fields. Crusting. What would crusting indicate? Anybody get crusting? Infection? Could be infection. Could just be allergies. My cat gets crust. I'm taking out his crust.
gross.
So pupils, we want to assess that they're equal, that for symmetry, that they're equal in size, that they're round. If they're not round, if head trauma or a stroke could have happened. The size are in millimeters. And if your pen lights come with a little pupil gauge on the side when you bought it, that's the best way to just look at your pupil gauge and then look at the pupils and get a good estimate of how many millimeters large they are. So, PERLA stands for equal, pupils equal, E is equal, that the round is the first R, that the reactive, the second R, L is to light, that they're equal, round, reactive to light, and A stands for accommodation. And accommodation is the hard part. You want, when you're standing in front of a patient and assessing their accommodation, you want them to maybe look at your nose and then have them look at an object that's behind you, like look at my nose and look at the P and pupils. And then to look back at your nose again. And what you're going to see as you're telling them to do that is their eyes focus on your nose and then focus on the distant object and then focus back on your nose again, and their eyes will cross a little, by looking at such a near object after focusing on a far away object. So you want the pupils to constrict when they're close because they're looking at something closer. They get a little bit wider when you look away, and you want that constriction or dilation to happen, and also that little bit of a crossing of the eyes, and not a permanent fixed cross, it just for a second there it crosses, and that's called accommodation. You want them to be able to focus near and focus far, and be able to adjust pretty quickly. Okay. When another thing that we should do with our pen light when we're assessing for pupils, we want to look at pupillary response and the direct and consensual reaction of light. So if I were to put a paper, and you want to take somebody's glasses off when you assess their eyes, you want to put a paper, and if I were to put a pen light in my right eye, my left eye should constrict a little bit too. It's just a consensual thing that happens to the opposite eye. So that's something you could assess this weekend if you have your pen light in your pocket. It's part of the uniform. You should have a pen light in your pocket, right?
Yeah.
I wish I was down in Roxborough, Michael.
I don't think you would give me death threats like.
She's not over there.
Oh, never mind.
Death threats.
Threats of bodily
Peripheral
harm.
vision. Another part of the eye exam when the person has the pen light or a pen, and they ask you, when does the pen come into focus, and then you indicate when the pen comes into focus on your periphery. perception to light, movement, counting fingers, counting objects. So you can, walk 5-6 feet away and then hold up how many fingers and ask the person how many fingers you have up. To test near vision, you give the person a newspaper or a menu to read. That E chart on the side is called the Snellen chart. Kids that don't know their alphabet yet often have an E chart, just a bunch of E's, and they'll say, they'll tell you which ways the E's are going by moving their hands. Or sometimes they'll have pictures, like a sun, a house, a moon, a cat, those types of things, and they'll be able to tell you. And by standing 20 feet away from the chart, it'll indicate what your vision is, 20/20, 20/40, and whatnot. 20/20 is perfect vision. You should see what perfect eyes see at 20 feet away. If you can see, line 5 or whatever the indication is. I think I'm 240/20 or something crazy. When somebody with normal vision can see at 240 feet, I can only see at 20 feet. Not crazy, but I'm really blind. And I pay a lot of money to use up like Coke bottle glasses. Too much money. Assistive devices, glasses, contact lens, artificial eyes. Artificial eyes aren't really assistive, it's just that when somebody loses an eye, just so their eye socket doesn't cave in, they have an artificial or glass eye. They're not glass anymore, they're like a polyester, but they're pretty heavy. And they're, orb shaped to fit right to the socket. Eye patches are used when somebody has a lazy eye, and what will happen is they'll put the eye patch over the good eye in order to make the lazy eye stronger and see better. Yeah.
And it might be a weird question, but if they have the artificial eye, do you still get the tear ducts to lubricate, or is it kind of?
The tear ducts still do have lubrication. Oftentimes you, in order to put the eye in, because people will take the eye out to clean, because it's not as good as lubrication as in when you have all the optic nerves and all the lacrimal ducts still functioning.
Oh.
So oftentimes you do have to, not soak, but to wet the eye, the artificial eye in saline in order to pop it into the socket.
I'm just thinking because they're blinking, you you gotta eventually start.
Yeah, still blink normally, but because we take the eye out because it does get dried, and because we don't have the drain system anymore, it doesn't clean as well as our real eye would. So taking it out to clean it and popping it back in is what we have to do.
Gotcha.
There's a lot of drying that goes on.
That's sterile technique?
It's not. So some eye terminology. Myopia, that's just nearsightedness. Presbyopia, we learned when we talked about gerontology back in week 2 or whatever the heck that was, years ago. Old eyes, it's farsightedness, but it's typically what old eyes get.
Wait, is that?
These, there's actually
So it's old
no
eyes.
part
Old eyes,
of
farsighted.
the
Okay.
final competency that you're going to have to do an eye assessment. I don't believe any of the scenarios do that. You didn't hear me say that. But yeah, don't commit these to memory. They're, we're not eye specialists. We don't work for an eye doctor. Yeah. Astigmatism is just blurry vision. The cornea is irregular shape. That's why we have the blurry vision. Cataract is that lens becoming opaque, and it's and blurred vision is the result. Nystagmus is uncontrolled movements and vision, like a shaky eye. And a strabismus is cross-eyed, like one eye's looking at an object, the other eye is sort of not, and it's misaligned. That's strabismus. Yeah, don't. They're Paltro's eyes, that's all. That's the ear. classified as wax. We need wax to protect our inner ear from bacteria, fungus, water, insects. Wax is really protective. I had an ear infection last week, and the chick down at the CVS.
Chick, I'm rubbing off.
The nurse practitioner down at CVS says I cleaned my ears too well because I had I got water in my ear, and she said, "Do you swim?" I kind of giggled at her. I'm like, "No, on vacation, like last summer is the last time I swam," and she's like, "Oh, you have swimmer's ear." I'm like, "Okay." I had an inner and a middle ear infection, and it's because I just cleaned my ears I had no wax to protect it from the water that gave me the swimmer's ear, and I was in severe pain. What was I getting at?
How clean your
The wax, it's important.
Too
Don't
clean.
throw the wax out. Hearing aids are expensive. Hearing aids are like $1,500 to $3,000. You can get an amplifier at like CVS or Rite Aid for like under $100. And then cochlear implants is just a surgery to get the sensory neural function back. And they're like 10 grand.
More than that.
More than 10
Yeah, we
grand?
do them at my place. They're about 30.
Really?
Yeah, they're 30 grand. Yeah, that might be for the pair. I don't know, but
Okay.
Yeah, they
Yeah.
normally charge them per pair. Because they do that for the hearing aids at Jack too. They charge per pair.
yeah. So there's two separate surgeries, but because they only do one at a time for some reason. I don't know why they don't do both at the same time, but we only do them one at a time.
I wonder what the recovery period is.
I don't know. I mean, we had a cochlear implant today.
Okay.
I'll
30
ask.
grand, wow.
30 grand.
Crazy. Versus neck, external ear, external nose.
Yeah.
Why would we need to assess somebody's nose before doing what?
NG2 or
NG2. To see if they have like a deviated septum or something, see if there's any blockages that we're gonna have a hard time going in. And then if you see a blockage, you go into the other areas. Okay? Lips, mouth, and oropharynx. Make sure dentition is in good condition. Prior to surgery, if they have any fake teeth, making sure that they come out so they don't choke on them during the surgery. Dentures, you can have a full set or a partial set, just uppers, just lowers. Plates are like partials, that they have some teeth and the plate goes around the teeth that they have. Cap teeth can be silver or enamel colored. Bridges for where there's spaces in the mouth. The thing with any of these assistive devices for eating is how they tolerate food. Some people take their dentures out to eat because they're ill-fitting, and so if they're ill-fitting, they can't chew properly. So of course, if they're taking their teeth out, they're not able to chew steak or something like that. So how can they tolerate their diet? Can they eat some with the teeth? Do they cut their corn on the cob so it's just corn and not on the cob anymore? That type of thing. Inside of the mouth. So neck, and we'll go into all the musculoskeletal system. So the neck, we want to do range of motion. We have flexion, extension, and then hyperextension going past extension. Ask for comfort, discomfort, if they're having discomfort, if they're having stiffness. Just like with everything leading up to this, we're checking everything for symmetry, so make sure things are symmetrical, that they can touch their, left ear to their shoulder, touch the right ear to their shoulder. That's flexion, extension, and then none of them show hyperextension, but hyperextension would be all the way back here on the first slide, first picture. So the respiratory, thorax, we're checking for symmetry, shape, spinal alignment, or, as we look at them from behind. Any deformities. Just showing the midclavicular and the mid-axillary line for, when you're documenting things and where you're finding things at. Normal anterior posterior diameter. I'm not sure, did we talk about this in respiratory? We talked about it. So what does that mean?
Oxygenation, we know, is a big area for growth.
What's this here? This
What did
is
you
the
say?
spinal cord. So the anterior posterior diameter, what normal is this
Barrel
side. So
chested or
we have
something.
side to side. We want to be in a ratio of 1 to 2. So our anterior, posterior would be 1, to the width would be 2. So that's the, if somebody had, COPD for a long time and they're what they call barrel chested, this would be like a 1-to-1. So this would be more of a circular and not more of that, like an oval. Okay, so you want it to be 1 to 2. This anterior posterior diameter. We will inspect for masses, tenderness, abnormal movement, abnormal, rising and falling of the chest. We also take front and back all the time, front and back. How many sites do we auscultate in the front? At least how many? 8, at least 8. How about in the back? At least 10 to 12, 6 on each lung. Okay. How many lobes do we have on the right side? 3. Do we have 3 on the left side?
No.
How many on the left?
2.
And why is there a difference?
The heart.
Because the heart. So we're assessing rate, which is how many breaths per minute. The rhythm, whether it's regularly irregular, or irregular, like erratic, meaning that there's no regularity to it at all. And the pattern is the distance between breath 1 and 2, breath 7 and 8. It should be the same amount of time between each breath. That's the pattern. So the 3 types of breath sounds are bronchial. So that's the louder sounds that are heard over the trachea. Bronchiovesicular, we're hearing them over both lung fields. They're moderate in sound, and it's like a moderate blowing of air through the large airways. And then vesicular, the soft, lower pitch sounds that are going to be over like the bronchial trees. Okay? So bronchial over the trachea here, bronchial vesicular, and vesicular. Adventitious, crackles or rails, coarse popping when you have air in the small, fluid in the small airways. Anybody ever crackles at clinical? No. Bronchi, pitched gurgling as the large airways fill with fluid, so it's also fluid, but it's more of a, it's like a lighter popping, if that makes any sense, and it's hard to explain. There's a zillion YouTube videos, as long as you look at a reliable site like Mayo Clinic or something that you use, Google.gov or CDC might have videos. Wheezes, wheezes we can hear without a stethoscope. A narrowed airway is going to be a high-pitched whistling sound, like a scary movie forward when somebody's like, going through a haunted house, and it's that floor creak, that really high-pitched, scary movie floor creaking sound. Like Jesus. there's the auscultation site, there's 10 here on the anterior here, and
Will be.
18 on the back of the car there, but at least 8 on the front and 12 on the back. Breast exam. How
Also, I
often?
have a question,
Okay.
how about oral? Should the person's mouth be open or closed when you're also doing the breast sounds? When you tell a patient, should they have their mouth open or closed? Everybody's thinking. No one's answering.
I think you should tell you to breathe in through your nose and out through your mouth.
Right, so your mouth's open. And again, practice this, you can practice here, practice with each other, but practice in clinical. You get a much better sound when a person's mouth is open, if they can be compliant with it. Like some people just, they can't get it, but if they can do it with their mouth open, you just hear things a lot better than if their mouth's closed. And also another little trick is if you have them, if they can do this one too, not everybody can do it, but you have your have them cross their arms or something like that, that moves the scapula out of the way in the back, so you can have a better feel to listen for posterior. So the steps of the assessment, for respiratory assessment are gonna be what? What's always first? Beautiful, inspection, then
Listen.
auscultation, beautiful. Then right now, they're saying hold off on percussive palpation, but you can percussive palpate before you can get to.
You wanna make sure you get in between the ribs if you're percussing, because you're just gonna hear a thud, of the hard bone if you're not in between the ribs.
Well, I'm sorry, who's saying to hold off? What, just because we're 100 students, we're holding off on percussion and publishment,
Or
or?
you can't comment.
I thought you knew something I didn't know. I don't
Yeah,
know.
or-
It
it's
says it multiple
scientifically.
times in the PowerPoint.
Oh,
There's so many.
okay, sorry.
I don't know what the hell's going on right now.
Controversial.
Percussion.
No, I know, I think I know. Yeah, I know.
Percussion for the most part was a diagnostic tool before radiography, before x-rays. So we have CAT scans and ultrasounds and x-rays that, percussion just has gone to the wayside, that even old school docs aren't even using it anymore. Nurse practitioners really aren't even using it. I've never seen it practice.
And definitely palpation, you see something
Oh,
weird.
yeah.
Go ahead and palpate. It's just feeling it. I'm not gonna bring anything.
There's no breast exam in the final competency, but this is just part of the head to toe assessment. How often should we do a breast exam? How often do you get a breast exam?
Never.
So once a year? Never? You've never had your breast examined?
Men get breast cancer.
Yeah, men get breast
And
cancer.
then get breast cancer.
Ask for it next time.
I've never,
You
just,
can do it yourself, actually, too.
okay, next subject.
Next slide, please. We need to, it's every 1 to 3 years, and there's different, books will say different things. 1 to 3 years, starting at age 40, starting at age 30 sometimes. Females, should be instructed to do self-breast exam once a month at the same time of each month. Circular motion, starting at the nipple, going in concentric circles like the target sign, to the outer, and then you go up the axilla to feel if there's any enlarged lymph nodes. The heart. We're going to inspect and palpate. We're going to observe for abnormal pulsations or heaves. Feel for the point of maximal impulse. Where are we going to find that? Where is that?
This intercostal space, mid-clavicular line,
What side?
left.
left side, fifth intercostal space, so 5 spaces down. Midclavicular line, here's the clavicle, here's the middle of the clavicle, go straight down. That's the point of maximal impulse, and what valves are closing at the point of maximal impulse? Mitral tricuspid. And so the point of maximal impulse is at what part of the heart? Is that the base or the apex? The apex. And that we can palpate. We're also gonna auscultate it. That's where we're palpating it. So midclavicular line, left side. Right about here. Right there, we're gonna feel it. Auscultation sites, we have A, P, T, and M, 8 to man. It's the T or the E that we don't have them before.
Herb's point,
We don't do it. We don't do
deleted
it.
in this text. Again.
They delete. That's why rocks broken, that's a textbook thing. Usually I'm complaining that rocks broken. But, so apical, what's the P? Pulmonic, so apical we have over on the right side. Pulmonic directly on the other side, on the left side. Herb's point, which is no longer a part of the heart, according to our textbook. Tricuspid is down at the fifth at the sternum, and then mitral is fifth at the midclavicular, okay? And they're the 4 spots we're going to assess cardiac-wise. So whether you're clinical, whether you pull that one out of the hat for the final competency.
But Herb's point is where like you hear murmurs at usually, right?
At the base of the heart, yeah, you'll hear,
You can
you
hear
can
it.
hear murmur at any valve.
Okay.
But so that's just as large as the other valve, so you really hear them there too. So here's the position you want the patient to be in, supine or head of the bed, elevated. Hopefully that says 45 degrees, yes. Sitting upright or leaning forward, you're gonna hear some sounds better if you lean forward. Lean to the left. And again, just when somebody has large breasts, you have to displace the breast to hear sounds. You might not hear things the best at the 5th metatarsal space, but that should be the point of maximal intensity, but you might have extra tissue, breast tissue, the patient might be obese, and so you might hear better at the flank, okay, or a little bit closer to the side of the chest. Heart rate, how many beats per minute? What's the quality? Is it bounding? Is it, what else can I have? Help me out. Ready? Ready? We're gonna hear it, Freddie?
Oh, I'm sorry, I missed
Yeah,
it.
that's what I was trying to figure out with the heart.
Like
Regularity.
labor, non-labor? Oh, no, that's.
Regular, irregular, so we're getting auscultation wise.
For rhythm, you're gonna have regular or, irregular, but you could have a regularly irregular pattern, like there's a skip every 7th beat or something like that. So you wanna, that's one of the main reasons we listen for a full minute, so we can, hear everything. And those are the 4 areas that we're, gonna listen: aortic, pulmonic, tricuspid, and mitral. S1 is the first hard sound, it's dull, it's lower pitched. It's when the tricuspid and mitral close, and we hear it best at the apex. S2 is the second hard sound, and it's higher pitched than S1, and that's gonna be when the aortic and pulmonic valves close. And that's gonna be heard better at the aortic and pulmonic areas, which is down up at the, right to the right and right to the left of the sternum, the 3rd space down.
And that's diastolic, right?
That is the S2 sound. Diastolic is when we're talking about blood pressures. Peripheral pulse is anywhere that there's an artery close to the surface of the skin. So temporal pulse, carotid pulse. Carotid, what do we need to remember?
Only one at a time.
Only at auscultate one at a time. Brachials at the antecubital area, radial. Ulnar pulse, I've never been able to find one. It's a little bit too deep. Femoral. Posterior tibial, popliteal aren't on here. Also the dorsalis pedis at the, on the foot. So grading scale for pulses, what if you were to go to clinical and the pulse is absent and we're gonna grade that as 0? What are we gonna do? This Saturday morning, 8 o'clock, we find a pulse that's absent.
Doppler.
Get a Doppler. Yeah, you never put 0 as a pulse, ever, never, ever. Unless it's truly, you know, call the physician and then document it. It's a 0 pulse. It's a problem. Unless it's been 0 all along and we've been using a Doppler all along. But we want to get a Doppler to make sure there's indeed flow to that area, whether it's the foot or the radius. Okay. So absent is 0. Plus 4 is bounding. 2 is normal. Normal pulse. A little bit more than normal is increased or full volume. Sometimes little old men and little old ladies have the +1. Diminished, ready, you know, not too easily felt, very easily obliterated. So you put light pressure and a little bit deeper pressure, it's going to obliterate it. All right, so now we're going to talk about GI. GI, typically we're going to listen to all 4 quadrants of the abdomen. And the 4 quadrants are separated by the umbilicus. We can get really heavy duty into the body parts and divide it into the 9. How often are we going to listen to sounds in the belly? Like how long should we listen for?
2 to 3 minutes.
2 or 3 minutes, or less if we're hearing things already. How long should we hear before we determine there's no vowel sounds? 5 minutes. Right. If we were to document hypoactive vowel sounds, how many vowel sounds per minute would we hear? I think we ever talked about this, but it varies per textbook, but it's like somewhere between like 3 and 7 or 3 and 10, they say. When, you know, knowing what body parts we're listening to could be very important when there might be a bowel obstruction, or when there's hyper or hypoactive bowel sounds. In terms of, you know, are they post-surgery, and hypoactive bowel sounds aren't a problem, but if they are eating and having bowel movements, but their last bowel movement was Monday this week, we might not have any bowel sounds today, and then that might be a problem. You know, why don't they have bowel sounds? When we inspect, we're going to look for different things, like scars, striae, which are stretch marks, venous patterns, any lesions, any marks on the belly. Shape and symmetry, belly should be symmetrical. Is there distension going on? Can we see fluid or peristaltic movement if they're really skinny? Any pulsations if they're really skinny? That's a mid-abdominal incision from like pretty much the sternum to the belly button. Striae here, striae here. Probably just from, they both look like men because of the hair. Probably just from gaining weight. Different abdominal contours. This is flat at the top. Scaphoid, when somebody's laying flat, they're like their rib cage sort of sticks out, but they have like a really indented belly. This is rounded, and this is more obese or protuberant. is how you would document that. Ascites is when we have that enlarged belly that typically has something in it, and usually air, but it could be fluid. And when we're doing percussion, is what's going to determine what's underneath. If it's fluid, when we percuss, we might see waves go across the belly. This here is ascites, and we might have tympany at the top and dullness at the bottom, because that's where fluid might have settled at the bottom if they're laying on their back. But tympany in the air-filled area is going to feel like a drum. It's going to sound like a drum. Down here, we can have air, or we can have feces in the colon. So if we're percussing over their descending colon, and there's feces in there, we're going to hear more of a thud than an air-filled sound. We're going to auscultate before we percuss, because why?
Won't dislodge anything.
Not dislodge it, but we want to auscultate before we palpate or percuss, because palpating and percussing could start up vowel sounds that might not have been there, or might make normal active vowel sounds sound like hyperactive vowel sounds when we're poking and prodding. Okay. Why are we listening for 5 minutes in each quadrant? But why would we need to listen for 5 minutes? If we didn't hear anything. So we want to give it that full 5 minutes before we determine, hey, there's nothing there, or they're hypoactive at least, okay?
So is there a point where you could literally like listen for 20 minutes?
Yeah, yeah. I never had to listen to for 20, I've never had somebody with absent vowel sounds, because I did hear something within 5 minutes. And the sounds came quicker in the other quadrants, so it wasn't a full 20 minutes, but I probably listened for 12 minutes. That was the longest I've ever listened before I was able to determine. How about you? You ever listen for 20 minutes?
I'm not able to listen to 5 minutes. If I don't hear anything in 5 minutes, they're hypoactive. Sorry.
But if you don't hear anything in 5 minutes, that's a problem.
Correct.
Like another, like some kind of obstruction.
Yeah, I mean, but yeah, I mean, but textbook answer, yes, you would listen to another quadrant, but I'm being very realistic with you. You're not standing there for 5 minutes.
5 minutes will seem like 20, and 20 will seem like an hour, really.
Definitely. I mean, I'm sure everyone's have
Some
other,
other things you
you
can
have
do.
four other patients.
Yeah.
But, I mean.
But that's why, again, that's why don't document no vowel sounds, because that means you were there for 20 minutes, and that's a lot.
Just pray that the vowel sounds confident.
There, if you were really there, but.
This is just indicating that they're hooked up to a sonogram of sorts to indicate hyperactive, a lot of vowel sounds, to hypoactive, not too many. Okay? And normoactive is vowel sounds in all 4 quadrants, normal vowel sounds in all 4 quadrants. Lastly, we palpate and percuss. We ask the elimination questions, you know, when was the last time you had a vowel movement? What does your vowel movement look like? Especially if it's a new patient, so you know what their norm is. If their norm is every 3 days, then we don't have to worry until the 3rd day that they didn't have a vowel movement. But if their norm is twice a day, and we're going on day 2 without a vowel movement, there's a problem possibly. Are they passing flatus? Do they have any stomas, any scarring on their abdomen? Male genitalia. Not a part of our assessment at the end, our final competency, unless we pick Foley catheter, and the GU part of the assessment would be inspecting either the female or the male genitalia. If there's a male scenario and a female scenario, in the various fields. And it would just be inspecting, to make sure that we're gonna be able to insert this, catheter. Most of the assessment for the GU assessment would be after that, the color, odor, consistency, amount. There's not much else besides the questions, you know, how often do you void, what color, do you have any odor, is what you could ask for. We can't really internally, assess the kidneys and bladder, you know, for that GU assessment. Female genitalia, again, we need, you know, what to, cleanse. We're gonna have to verbalize what you're cleansing, for the final competency. These elimination questions will either ask presence of stomas or other urinary collection devices. Are they voiding every shift? Are they voiding 30 milliliters an hour? You know, is there catheter draining at least 30 milliliters an hour?
And remember, we're at 4.30, what are we going by? Going by milliliter per kilogram per hour.
Right, we're accurate.
So how to convert their pounds to kilograms.
How do you convert pounds to kilograms? Multiply it divided by 2.2. Divide that. Muscle strength, inspection and palpation in standing, seated, lying positions, you know, have them push the gas pedals against your hands, have them, resist you, putting their, feet towards their nose, having them lift their legs, having them flex their knees, having them flex at their hip. Is their strength symmetrical? Any atrophy or hypertrophy? Assess gait and posture. Muscle strength, I've never honestly had to document muscle strength. It was always more of a occupational therapy and a physical therapy type thing. But 0 out of 5, meaning that they don't have any strength at all, no detectable muscle contractions happening. Grade 1 out of 5 is barely detectable contractions. 2 out of 5, they move their limb when you're not, they are able to move their limb, like when they remove their hand, you remove your hand, and they can keep their hand there. They have enough strength to do that. 3 out of 5 moves the limb against gravity, so you're holding their hand down and they're able to lift their hand up. 4 out of 5 moves limb against gravity with some resistance. And 5 out of 5, they're able to move their limbs with full resistance, so their arms and or their legs. So range of motion, you want to assess for range of motion of all the joints, you know, neck joints, finger joints, knee joint, hip joints, ankles, okay, every joint they have, every movable joint that they have, their cranial sutures for goodness sake, but we're going to, any joint that should be movable, we're going to assess, and assess for symmetry, that they're, have equal range of motion on each side. Palpate for unusual joint movement or crepitus, like when they, bend their shoulder, or their elbow, or their wrist, do you feel any like Rice Krispies underneath, you know, could be arthritis, or crepitus it's called. Stiffness. Palpate for warmth of joints. I mean, you want your skin to be warm, but warmth in the joints would feel more hot than warm, okay? Listen for abnormal sounds like the creaking. I know sometimes when I get on my knees creak, so you can hear that if the room's quiet enough. Their gait, are they steady or unsteady? Do they use furniture to get along, or hold on to the wall, or hold on to the furniture? Or do they use a cane or a walker? Are they ataxic? What's ataxia? Anybody?
Unsteady gait.
unsteady gait, it's really things that mimic being drunk. You know, unsteady, stumbling, falling, uneven, they have an uneven gait, they have a wide base. You know, do they have to walk with their legs wide apart in order to be steady? Do they have pain on movement? And of course you would inquire, you would ask about that. And this is more of a general stuff at the end of the assessment. Any tubes and documenting any tubes, do they have IV access, do they have surgical dressings? If they have dressings and wounds, do a wound assessment, a pressure injury assessment, assess, do a graded scale of the different, risks for, getting a pressure injury, a pressure wound. And these last couple slides are just all the slides sort of wrapped up into one. Neuro, we're gonna inquire about mental status, the Glasgow Coma score, their cranial nerves, gait, sensation, motor function. The skull, we're gonna actually look at, at their hair and their hair distribution. How's their skin look, their faces, do they have a drooped face like a stroke? Do they have the Parkinson's faces, like the mask-like gesture? Eyes, we're going to do PERLA, the PERRLA. We're going to assess the pupils, how big are they? Their vision, close and far. Their sclera, is it normal in color, is it white? Conjunctiva, the layer over the whole eye. Lashes, sometimes lashes are crusty. You can get the little lice in your eyelashes too. Ears, sinuses, and nose. Mouth, look at the mucous membranes, the tongue, the teeth, are they in good repair? Neck and shoulder strength, arms, range of motion, sensation, pulses, their strength. The chest configuration, is it, the 2-to-1 anterior, posterior diameter. Listen to the lungs, listen to the heart, assess the breasts, abdomen, inspect and listen. Girth, measuring the abdominal girth is measuring at the point of the umbilicus, the belly button, with a measuring tape around the whole abdomen to see how big their abdominal girth is. Assess the genitalia, and then the legs, sensation, range of motion, skin, pulses, nails, and strength. Genitalia on the dummy is going to be easy. It's on a human, that's not going to be easy for you, I'm sure. So if you have GU, you're going to be assessing genitalia, or skin assessment, that's part of the skin. So.
Excuse me, ma'am, my name's
Yeah.
Mike. I'm
Any
gonna
questions?
assess your snatch.
So hold on to this.
Did you never already practice in the lab on the fifth?
No, we're, next week, I think already, isn't it? Yeah, next week.
Oh, okay. We also have lab on
We have
Saturday.
lab, the day before Father's Day.